translational and histological data from the Cancer Genome Atlas database.
Good morning, everybody. I'm Dr. Petrone Melo from University of São Paulo. I'm going to present my research, deep learning predictive model for prostate cancer recurrence using clinical and histological data from the TCGA database. Well, the localized prostate cancer is usually treated by radical prostatectomy, and the goal of the treatment is eradication of this cancer. We usually use PSA to evaluate the surgery success. But unfortunately, we have a biochemical recurrence rate of up to 30%. And we know that the adjuvant treatment after the radical prostatectomy have a significant morbidity. So choosing the right patient is very important to avoid some side effects that could be avoided. Well, to predict biochemical recurrence could help to better stratify patients for specific adjuvant treatments. Currently, we use mainly clinical features to evaluate the risk of recurrence. For example, these scores like the MICO score, the NCCN score. We also have the ISUP, that is a very important form of classification to evaluate the risk of recurrence in the future. But even ISUP has its limitations. We have the disagreement between the pathologists. We have a relatively coarse description of the tissue morphology. We also have some other features that can help us to predict who is going to recurrence, like extraprostatic extension, like vesical seminal invasion, positive surgical margins, positive lymph nodes. We also have the Decipher gene signature, but Decipher, for example, is a very expensive method. It's not widely available in Brazil. For example, the minority of the patients have access to this technology. And we also know that the prognostic potential of the morphological features is underexplored. And we think that artificial intelligence can help us in this test to identify what the best patients who patients will have biochemical recurrence. Well, so the objective of our study is to develop a deep learning model that predicts prostate cancer recurrence after radical prostatectomy using clinical data and histological images available on the TCGA database. So we use it to our study, a public database from the TCGA. We use it about 500 patients. Most of them were cured after a median of 5-year follow-up. About 80% were cured, and about 20% have a biochemical recurrence. The clinical parameters they use are age, tumor laterality, the primary Gleason pattern, the total Gleason score, the tumor stage, the margin status, and unfortunately, on this database, we don't have the PSA preoperative. That is a very important feature. Unfortunately, we didn't use because it wasn't available. And we also used the histopathological slides that are segmented and smaller tiles. For example, this is a complete image on the left of the image, and to construct our model, we segmented these images in smaller tiles. In the training set, we used about 80% of these patients, about 400 patients. Most of them were cured. We maintained the rate of these patients. And in the test group, the patients, we used about 20% of these patients, about 100 patients. And in this test set, the images of these patients were not used in any moments of the training. We used it to perform our model an EfficientNet V7 architecture to evaluate the images, and the clinical data. We use the multi-layer perceptor. We concatenate of this feature, and the output was a yes or no answer. It was cure or recurrence. About the results, when you evaluate the images, that tiles that I showed before, the validation set, during the training, we had an accuracy of about 82%, and when evaluate the test images, images that we didn't use during the training, we had an accuracy of about 81%. The precision was about 57%. The sensibility was low, about 24%, and the specificity was about 95%. What happened probably was an overfitting. We have a lot of cured patients and a low number of recurrence. So one of problems that happened probably was overfitting. Regarding the patients individually, we have an accuracy of about 8%, a precision of 55%, a sensitivity of 25, sorry, and a specificity of 94%. And below this, we can see that most of the patients, the model predicted that was cured, probably because during the training there was a lot of patients that were cured and a low number of recurrence. Probably we have an overfitting of this data. The limitations, we didn't use the PSA because it wasn't available. We have an imbalance between the classes. A small number of cases. We know that a machine learning model usually needs thousands of cases to become accuracy, to have a high accuracy, and we don't have a tumor segmentation in the images. We only show the model the whole image and try to extract these features of it. Finally, the conclusions based on this preliminary data, we believe that the artificial intelligence holds a significant potential in postoperative management and risk stratification of patients with prostate cancer, and certainly in the near future, deep learning tools will be an integral part of our daily practice, guiding our approach following radical prostatectomy. Thank you very much.
Questions from the floor?
Great presentation. And what should be the next steps to be available and to improve your model?
I think the important things that we must to do to improve this model is to increase the number of cases. As I said before, one limitation of artificial intelligence model in general is the data, the number of cases, the diversity of cases, cases with lesion 6 patients, lesion 10, a lot of different patients, different images. We also, it's important to have patients with different pathologies evaluating that image, because when we have just one pathology, the accuracy of the model is worse. So I think the main important things that we must do is to increase the number of cases and the number of centers, the number of pathologists evaluating the slides being higher. I think it's better.
Thank you. Do you have another question?
Yeah, so this is Sakamoto University. So when your model you didn't increase PSA, right? So do you kind of think about if you can put the PSA into the model to think increase sensitivity? And the other one is you show the recurrence data. Is recurrence or not? There is no time point, right? Maybe 2 years or 3 years, 5 years, but recur or not. So do you kind of think about set a time point of recurrence as well?
Yes, it was a very simple module. PSA is really important, and it was a limitation of our study. We don't have this information. I think if you had the PSA, the accuracy of the module will certainly be higher. And regarding the time, we only had this binary classification, just yes or no. I think that more robust modules trying to identify the time between the recurrence, it will be better. But in our model, it was a very pilot mode, a very simple model, one single center. We just answered these simple questions, yes or no. So it Must be improved.
Thank you very much. Okay, in the interest of time, we will move on to Dr. Anker and Dr. Wall, whichever is presenting the characterizing prostate cancer risk with gallium-68 PSMA PET